So we're all set.
We are indeed. Thank you.
Thank you. So good morning, everyone, and welcome to today's hearing of the Health and Human Services Committee. We'll be revisiting a bill we heard earlier, 1701. Last session. It's being brought up for a work session and additional information at this point. As you know, or as you may know, you can watch this on the YouTube channel and go to the legislative website, click on the drop-down Health and Human Services Committee, and that will take you there. Everything's recorded, so if you can't watch all of today's proceedings, you can go back and watch later on. I guarantee that there will be some technical glitches along the way. They're not planned, but they're predictable. So bear with us while that happens. Committee is familiar with all of its responsibilities. And if you're here to offer us some information, please make sure your name is appropriately identified in using the rename function if necessary, so we can know who we're hearing from. When you get moved from an attending capacity to a participant capacity, there's a checkbox that needs to be done. It feels like you're going into a black hole. You will come out the other side and you'll be within the committee hearing as a participant. The chat function has been disabled for those in the attendee status. And we ask that no content go into chat that isn't related to the flow of the committee's work. So let's start by having the committee members introduce themselves, and I'll begin with Representative Zager.
Thank you, Mr. Chair. Good morning, everyone. My name is Sam Zager. I am honored to represent District 41 in Portland.
And Representative Lemelin.
Good morning, everyone. My name is Michael Lemlin. I represent House District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Representative Perry.
Good morning. I'm Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Barron, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Representative Javner.
Good morning. I'm Representative Kathy Javner, and I represent House District 141, which is located in Penobscot and Washington counties.
Representative Craven.
Thank you, Mr. Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan.
Good morning. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glumber and Levant and Pedescan.
Thank you. Senator Moore.
Good morning. I'm Marianne Moore, and I proudly represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Thank you, Mr. Chair. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott, where I live, and parts of Kittery and South Berwick, and I'm the House Chair.
And I'm Ned Claxton. I'm proud to represent Senate District 20, which consists of Auburn, where I live, and mine at Mechanic Falls, Poland, and New Gloucester. We are ably directed, assisted by staff that makes the place run. So I'll start with Anna.
Hi, I'm Anna Broom. I work in the Nonpartisan Office of Policy and Legal Analysis, and I'm a little concerned that I'm going to be the one responsible for the technology problems today.
Well, I already asked for folks to bear with us when it happens. We just don't know when it's going to happen. And I don't see Sam with us, so we'll go to Karen.
Hi, I'm Karen Thomas. I'm the clerk for the Health and Human Services Committee. If you need assistance, please email hhs@legislature.maine.gov. And I have the utmost confidence in Anna, and it's going to all go smoothly today.
Okay. And we have some guests today. The sponsor is here. Representative Millett, do you want to introduce yourself?
Morning, Senator and Representative Meyer and members of the committee. I'm Sowen Millet. I represent House District 71, including the towns of Norway, Sweden, Waterford, and West Paris.
And we'll hear from some other folks this morning as we get started on 1701, the only bill we'll consider today. Let's start with Anna. Would you care to begin?
Yep, sure. Now let me see if I can start the first thing, right? Because I can't see it because it's not in the right place. Okay, can you see that? Somebody tell me you can.
I can see your email.
Oh, really? Well, that's not what I'm looking for. Okay, let's try that again then.
I'm glad you're staying in touch with Aaron.
Yeah, it's really not what I was trying to do. Okay. Now can you see?
That's better. That's better.
Well, see, that's just the first of many, maybe. Okay, so
can you hit plus one more time up at the top
yes,
there and
I
make
can.
it a little bit bigger?
Certainly can do that. Is that
Thank
big
you
enough?
very much.
Okay, good. All right, I am just going to give you a very quick refresher here. I do want to remind you that you did receive, so I'm going to go down to this, that you did receive an amendment from Representative Millet on the day of the public hearing. So this bill establishes a managed care program for all covered main care services. It requires the Department of Health and Human Services to issue a request for proposals for 3 managed care organizations that are able to operate the managed care program on a statewide basis. I do want to remind you this was from last year, so these dates would probably perhaps be changed anyway. By July 1st, 2023, the Medicaid expansion population, that those covered by the CHIP program and members that are categorically eligible under TANF must be enrolled in the managed care organizations. By July 1st, 2025, all eligible main care members must be enrolled in managed care programs. The bill establishes the requirements for contracts for managed care organizations and requires the department to apply for whatever SPAs or waivers that they might need. And it requires the department to explore options to create a plan that integrates Medicaid and Medicare benefits for individuals. I'm not going to read this part out. This is just a little bit just to sort of point you to the differences in the language between the original bill and Representative Millet's amendment. There's not a lot of differences. There's some differences of dates, some sort of specific tweaks to the contracts. So I'm not going to read that at this point because I feel like this is going to be your day to get information. So I think this is perhaps for later on. And I don't want you to get used to this because I'm not going to start summarizing testimony for you, but this was last year. So I just wanted to give you a quick refresher of where you were. So you did hear from the sponsor and submitting the amendment because the time frame was unlikely. The department was previously working towards managed care, that there's little emphasis on prevention or health measures in the current system, that there are a lot of states that have managed care Medicaid programs, and this is also more predictable budgets. You also heard from community health options, which you're going to hear from again today. You heard some concerns from the department about timing of applications and also the need for rate reform to take place prior to any transition to managed care. And you heard some neither for nor against concerns from various people, such as the Hospital Association and some of the Autism Society and so on. Questions about savings, the impacts on providers, quality, the populations that would be covered, and especially expensive services, including the intellectually disabled and behavioral health services. So the real meat and potatoes today is the presentations, which I was asked to put together. So, or rather, I asked other people to do. So you'll hear first from the department, and then Sarah Vanderwood has organized some presentations that hopefully I won't screw up the slideshows for. And you have received them all in your email as well. And then you'll also hear from Kevin Lewis, who may be on by 11:40, but is only available until 2 o'clock. So that's sort of the lineup for you. And I'm just sort of going to get out of the way, and at the end of the presentations, you can decide whether you want to have more of a conversation as a committee conversation, or whether you want to schedule another work session at a later date. So that's your call at the end.
So let's give Representative Millet a chance to speak to the amendment that was offered on that last day we considered this bill. Is there anything you'd like to add to what you've heard so far?
I don't think so, Senator. I think Anna's covered it very well as we presented the amendment, and I recall having conversations with you at the time, knowing that the bill came in late and that the timelines in the original bill were not realistic. So we modified the timelines, and I'm very appreciative of your willingness to carry it over and consider it today. And I think we got a good lineup of people that can speak to the amended version as well as where things stand today. So I want to commend Anna as usual and Sarah for working together and putting together a very interesting agenda for the day. So I'll just listen in, Senator, if that's okay, and commend you for your continued attention to this bill.
Well, thank you for being here, and we'll reserve the right to ask any questions of you if they come up during the course of this. So I see that Molly Bogart has joined us, and good morning.
Good morning. I'm Molly Bogart, Director of Government Relations for DHHS. And we have Michelle Probert and Olivia Alford from our Main Care team who are going to walk you through a brief primer on managed care and also the department's work on value-based purchasing. So if we could.
So we're waiting for Director Probert and Olivia Alford to accept their promotion to panelist. Interesting language.
And you know, Director Probert and Olivia, some of you may have met her, but she's our Director of Value-Based Purchasing within Main Care.
Thank you. Thank you for that. So welcome, Director Probert. Good morning. Welcome, Olivia Alford. I'll defer to you too in terms of who's going to go in what order.
Great, thank you. I went into the black hole there for a little bit longer than I was anticipating, so I was getting nervous that I wasn't in fact going to emerge, but I'm glad that I have.
That's why we mentioned the black hole, because a lot of people get nervous.
Good morning, Senator Claxon and Representative Meyer and members of the committee, and good morning to Representative Millet as well. And thank you for your invitation to the department and more specifically the Office of Main Care Services to present this morning. My name is Michelle Probert and I am the Director for the Office of Main Care Services. And Olivia, would you like to briefly introduce yourself?
Sure. So I'm Olivia Alford. I'm the director of actually what we now call delivery system reform in the Office of Main Care Services, as the unit that takes on initiatives that look to really improve the health of our members and the way that care is delivered across the state. Thanks for having us.
I will give advanced thanks to Olivia, who was a very active contributor to the presentation this morning. And she is here for when you all have questions that she'll be available to chime in with her expertise. So first, I will say that you may be all disappointed that I'm not just here to talk about rates, because I know I have a reputation for doing that on a regular basis. But never fear, I will. I have one slide on the topic of rate system reform because it is relevant to this conversation as well. So if nothing else, you can't accuse me of not being consistent. So as a reminder to everybody, Main Care provides health insurance coverage to, at this point, 1 in 4 Mainers, the vast majority of whom are low income, including many members with disabilities, older adults, serious mental illness, and special health care needs. We are, in effect, a health plan, and measured by the number of members who are in Maine, we are actually the largest health plan in Maine. Today, I'm going to start off with the basics. I hope that it is not too basic and not too repetitive for you all, as I know that many of you know a great deal about managed care, but I am hopeful that it is helpful for you to hear what managed care is from the perspective of the state Medicaid agency, because I think it is an important perspective and we all have different perspectives. So I will share my screen and give me a moment to make sure that I have everything situated. Okay, do people see the proper screen share and not the funny black screen?
No,
I
we're
saw it
all
now.
set. We're all
Okay.
set.
Excellent, success so far. All right. So as I said, we're going to start out with some basics about managed care, and also what I think is quite important, the perspective of what this means for our members, what it could mean for providers and for the state as well. And then very importantly, we also want to talk about a number of the efforts that MaineCare has going on currently that intersect with the conversation of a potential transition to managed care and also present some overlap with functions that managed care entities may also take on. Oop, I forgot that this was a fancy animated slide. All right, so don't worry, we're going to fill in the blanks. So on this slide, I'm talking about the basics of what I'll call really traditional comprehensive managed care. So under the system that Maine has right now, as I said, the Office of MaineCare Services really acts as a health plan. We contract with providers and we pay them directly for healthcare services. And providers obviously deliver those services to MaineCare members. Under a traditional, and this is really oversimplifying it, but under a traditional comprehensive managed care model, instead of contracting directly with providers, OMS contracts with managed care organizations. And those MCOs, we call them, have the contractual relationships with providers. And MaineCare pays the MCOs, the managed care organization, a predetermined set per member per month payment. That payment goes to the managed care organizations. They contract with providers to create a network. And then once again, the providers deliver those services to MaineCare members. So as I said, this is very oversimplified. It gets much more complex and nuanced in practice, and we'll be talking a little bit during this presentation about some of that variation and that nuance. I will note that one of the key pieces here is as MaineCare pays that set per member per month capitated amount to managed care, what that effectively means is that going forward for the population and services under managed care, the number of members who are enrolled is what drives the total cost to the state. The utilization piece of things is really under the managed care companies, and if it's more expensive than they thought it was going to be, then the managed care companies, they take on that risk and have the risk of potentially taking a hit. If they are able to meet all of their contractual requirements and are able to provide the care to members for lower than that capitated amount, then they profit. So as with many things, CMS plays a significant hand in states and their authority to operate under Medicaid managed care. There are a number of different special authorities that CMS has out there as options for states. Which authority really depends on a number of factors, including whether you want to make managed care enrollment mandatory for all members. There are certain members who, as the general rule, you cannot just auto-enroll into a managed care plan. For example, American Indian, Alaska Natives, individuals who are also enrolled in Medicare, who we often refer to as dual eligibles, and children with special healthcare needs. So if you want to enroll the full population, you need to take a waiver approach versus a state plan approach that we often talk about. And there are also a number of other factors that may determine what authority you need to pursue. That includes the degree to which you expect things to be uniform across the state or not, whether or not you allow members to choose which providers they receive services from, how comparable those services are. Those are all things that are often what states ask CMS to waive under a managed care program. But what Medicaid managed care all has in common is that regardless of the specific authority or what services are carved in or out or what members are carved in or out, all managed care systems the states need to have systems in place for quality oversight, for appeals and grievances processes, for members as well as for providers, and also need to demonstrate that the state through the managed care companies is providing sufficient access to care. So this is an intensive approval process, especially as a state is first developing managed care, and CMS gets very involved, including in review of individual contracts, so it can often be a very lengthy process. So where did managed care come from? I think that many of us remember discussions about HMOs back in the 90s, and discussion about Medicaid managed care really started around the same time. The intent of managed care was really to lower costs, to improve member access, to improve quality, and also to gain that predictability over state Medicaid budgets that I was talking about. And the theory is really that managed care organizations would be able to do this work more efficiently than states. The hope was that managed care organizations would thus be able to actually improve payments to providers, which would help result in a better access, better networks, and better access to members. And that also with a capitated payment approach, managed care organizations would be able to direct members to lower cost and more prompt care. So that was really why managed care was created for the Medicaid program, and it's been a pretty meteoric rise in terms of the number of states who participate in Medicaid managed care. So in 1990, about 10% of members enrolled in Medicaid nationwide were under managed care plans. And just within 10 years, by 1999, that was already up to 55%. And that was back in 1999. So a few years have passed since then. And where is Medicaid managed care now? So on this slide, first, I will note that these screenshots are taken directly from a website for a podcast that is called Trade-Offs. And coincidentally, this past November, the Trade-Offs podcast had an episode that was called, "Has Medicaid Managed Care Delivered on Its Promise?" So I highly recommend that everybody listen to it. It was very well done. It's only like 22 minutes long, but they managed to convey a lot of valuable information in that space. And it's been regarded in many circles as an excellent, quick, high-level take on the question of what has the impact of Medicaid managed care been. So definitely recommend that folks take a listen to that podcast if you have the opportunity. So as reported by Trade-Offs and reflected from data from the Kaiser Family Foundation and Health Management Associations, there are now 41 states, including DC, that offer comprehensive Medicaid managed care. 360 billion is spent nationally to managed care organizations that are under this comprehensive model. That was in 2020. And almost 63% of managed care beneficiaries are enrolled in plans that are run by multi-state commercial insurers. So there are also states that have local government organizations as well as community-based organizations that play the role as the managed care organization, but that is more the exception than it is the rule. If you look at a measure of just the percentage of Medicaid members that are in comprehensive managed care, that percentage is actually 70%. So you can look at about that 7% difference, and that 7% represents Medicaid enrollees who are in those more, whether local government or community-based organizations that are managed care organizations. So it's very clear that many states have been compelled by what managed care organizations can offer to the states. And so the question that we have is, how well is it working? How well are Medicaid managed care organizations have they been able to meet those goals of improved access, quality, under lower cost? The first thing I'll say, which often comes up in evaluation when you're speaking about healthcare, is that it's a hard question to answer, especially because the way that Medicaid is structured nationally, generally speaking, and specifically in respect to managed care. So I said there are 41 states, including DC, that have comprehensive managed care. That means that there are 41 different ways that managed care is structured across all of those states and DC. The way managed care is structured, as I referenced earlier, there can be a lot of variation in terms of what populations are and are not included. There can be variation in terms of what services are carved in or carved out of managed care. For example, some states do not have behavioral health services included in their managed care. The majority of states don't include long-term services and supports in their managed care plans. Pharmacy, there's a trend I'll speak to a little bit later on how the majority of states do include pharmacy, but there's been a bit of a trend lately towards states carving pharmacy out of their managed care. And then there's variation in dental as well. States also vary pretty significantly in terms of the number of managed care organizations that they contract with, the degree of choice that they allow to members, the geographical distribution of those health plans and coverage areas. And then there's also a fair amount of variation in terms of the degree of focus on value-based purchasing, as well as how different states promote value-based purchasing through the different health plans. Sometimes states are very prescriptive, and similar to what Maine has done, the state itself designs the program and then requires that the managed care organization administer that program essentially. Other times states just say to the managed care organization, we have the expectation that you have these value-based kinds of arrangements, and leaves it to the managed care organization to determine what that looks like. So managed care under Medicaid from the very start was never black and white. There was always a lot of variation in terms of these different factors. But I will also note that over the past decade, there are even more shades of gray than there used to be. So it's really not a question of managed care or not managed care anymore. And I have just a couple examples to illustrate that. You absolutely still have many states that participate in what I would say is the more traditional managed care that reflects that initial slide that I showed to you. As an example, West Virginia is an example of a state that has pretty traditional managed care relationships. As a different example, Oregon, starting, I don't have the year in front of me, but I think around 2012. So they have a managed care model that they actually have 16 regions, so quite a few regions across the state of Oregon. And they require that the managed care organizations for each of those 16 regions be community-based organizations specifically. So that is still considered managed care by CMS, but it's got a very different flavor than the more typical managed care that you see nationally. And then I will also mention the state of Massachusetts. Massachusetts also has official managed care authority from CMS. They have intentionally been moving away from traditional managed care and focusing on a hybrid model with their accountable care organizations. So Massachusetts is really looking at health systems who are accountable care organizations or ACOs to partner with a health plan. Or their other model is for the ACOs themselves to take on the risk associated with capitated payments. And so that is yet another example of something that is still referred to as managed care, but that looks really different from models in other states. I could go on, but I'll stop with those three examples because I think that they're pretty effective at displaying the diversity of arrangements that we see across the country. So takeaway from that slide is that there's a lot of variation in what managed care actually is and how it operates and who it impacts. My slide is freezing and doesn't want to go forward. Okay, there we go. Representative Perry, did you have a question?
Well, yes, I did. I know there was a time in a previous administration where we were actually beginning the process of creating or working managed care into the system and showing some real savings in health outcomes and emergency room use for our higher use patients. And I'm wondering if some of that work is still going on, or did that end with the new administration?
So I think that this might come down to the question of how are you defining managed care? I will say, so I joined Maine Care for the first time in 2011, and it was at that point that the state was on the verge of implementing what I've been describing in today's presentation, which is comprehensive managed care. The state was on the verge of issuing an RFP, but those plans were put on hold by the previous administration. And so managed care, as I've been defining it in this presentation, was never implemented. Having said that, and I will be getting to that in this presentation, there are a number of activities and initiatives and systems that Maine Care has in place that reflect activities that managed care organizations and health plans do in other states. So I think that that's what you're getting to, and I can speak to that more as we go forward.
Thank you.
All right, so it's hard to evaluate managed care, generally speaking. Nonetheless, I would say that it's good news that there have been lots of attempts to evaluate managed care. Over 3 decades, there have been over 60 peer-reviewed studies, and the results have been mixed, I think in part because it's hard to evaluate. So there have been a few studies that show that managed care has lowered costs, expanded access, or improved quality. Most studies have shown, did not show an impact that they could measure or showed negative impacts. There are a smaller number of studies that were specifically looking at the impact of managed care on health equity or reducing health disparities, and those also showed mixed results. So there were a couple of comprehensive literature reviews. One was in 2012 by the Robert Wood Johnson Foundation, and then more recently, there was a literature review in 2020, an annual review of public health. And these studies are also referenced in the Trade-Offs podcast that I encourage that you take some time to listen to earlier. And so the quote from the most recent comprehensive review is that while there are incidences of success, research evaluating managed care programs show that these initial hopes were largely unfounded. And the caveat there, of course, is that there's variation, right? And there is no doubt that there's been more success in certain programs than there have in others. And so really at this point, managed care is a very big investment. I think it's fair to say that once a state has implemented managed care, it is hard to step back. The focus has really been, how do states get the best value out of their managed care relationships? And that has really been the question, not whether or not states should still be, that have been engaged in managed care, should still be engaging in managed care. The focus is really on, for states that are implementing managed care for the first time, that you really need to be thoughtful about that implementation, that you need, it's recommended that you have intensive stakeholder engagement, that you have a very careful procurement process, that you allow yourself considerable time in order to implement. And when you have managed care in place, regardless for how long it's been, strong contract management is really critical, and having the infrastructure for that contract management And more and more frequently, states are really focusing on pretty aggressive contracting techniques, focusing on performance expectations and tying managed care payment to those performance expectations. I will briefly mention that really at least the most famous exception to states not backing out of managed care is Connecticut. Connecticut had managed care for decades, but I think about 10 years ago, they decided to discontinue their managed care, and in its place, they have some administrative service organizations that assist with administration of the program. And Connecticut has been able to demonstrate evidence of success, both in terms of reducing costs and some metrics related to quality since they made that move. So transitioning from discussion around evaluation, I think it's really important for all of us to think through what managed care actually means on the ground. First, I will say that these are meant to be examples. It's meant to be a slide that is illustrative. It is certainly not comprehensive. And because what managed care is and looks like really varies a lot by state, these examples are not true for every state that has managed care, but I still think that it's helpful just to think through implications of what this direction would mean. And before I get into the details, I'll actually focus on the bottom of the slide, which states the fact that at least based on my understanding of the current bill, main care would still need to have the functionality that it has today for the populations and services that would not, at least initially, be enrolled in managed care. And Office for Family Independence would still need to determine eligibility. So there are many, many big changes that require adequate resources for the state to oversee managed care. And at the same time, we still need the infrastructure to do what we do today, even if it's for a smaller percentage of the population. Okay, so we'll start with members because they are our focus. So what does this mean for members? If in managed care states, members need to make a decision about what health plan they want to enroll with. And depending on who the member is or what services they receive, they might also need to interact both with the state, in our case, Office of Main Care Services, in addition to the health plan. So they could have more than one entity that they need to coordinate with to make sure they meet their healthcare needs. Members might have additional supports available to them that they are not offered right now. So managed care, one of the big benefits is that there's often a lot more flexibility under managed care than there is under regular state plan and waiver services. And so members might be able to benefit from incentives, receiving direct assistance to meet their social healthcare related needs. So that's a benefit. Also of impact to members is that their choice of provider may be restricted based on the health plan that they enroll with. And again, the impact on members also really differs or can differ depending on whether they receive Medicare as well, whether they are an American Indian or Alaskan Native, et cetera. So that is members. When we're speaking about providers, so providers would need to contract or would need to or would need to amend contracts that they may have existing with commercial payers in order to provide their services and get reimbursed. This will mean changes to operations for providers. So there may be different systems for claim submission, for prior authorization, for enrollment with the different plans. Also, on the theme of flexibility, providers may have the opportunity to negotiate rates. Different states do that differently. Some states say this is the rate that you have to get paid by managed care organizations. Other states leave it up to the managed care organization to negotiate. And then again, on the theme of flexibility, while the state is working on alternative payment models currently, under managed care, there is more flexibility as to how states, how managed care organizations can enter into those relationships with providers. And then lastly, what does this mean for the state? So I already talked about how a state would really need to maintain a dual system, what we do now, in addition to what we would need to do to provide the oversight and analytics for managed care. As I mentioned before, a big change is that there is more budget predictability. On the flip side of that, that does mean that there is less control over service expenditures. I will use the pandemic as an example because it was a big topic among state Medicaid agencies. So when the pandemic started and there was a big drop in healthcare utilization, all the states with managed care continued to have to pay those managed care organizations the same capitated rates that the MCOs had been receiving. And so that meant that those states had less ability to redirect those payments to providers, for example, to provide support under the pandemic. They were tied into those capitated amounts, and so they had less flexibility. There is shared risk and accountability. So again, a big benefit, and this goes hand in hand with budget predictability, is that the state really has the quote risk of needing to manage costs associated with increased enrollment, which we already do, but the state does not need to worry about the variation in the cost of care that's associated with a utilization of services. And as I've mentioned, there are extensive requirements for contracting oversight and compliance monitoring. It's also just best practice that you need to have a lot of resources focused on oversight in order to administer managed care successfully. And lastly, again, there is more flexibility from CMS in terms of trying out new things that may be harder to do if you are not a managed care state, like Maine is currently. All right, so big takeaway is that there is broad recognition that managed care alone is not going to clearly solve all healthcare problems for Medicaid across the country. We still need to make sure that payment to providers, for example, is sufficient to enable member access to care. We really need to have that robust analytics and oversight infrastructure to measure the cost and quality of care and make sure that we're seeing the outcomes that we want to see. And also, in addition to the movement towards more and more emphasis on contracting, I would also say that with or without managed care, reimbursement models need to reward value over volume. So a big piece of this puzzle that managed care does not solve in and of itself is that we need to transition our payment so that we are rewarding high value care directly to providers, that providers are sharing in accountability, and that we have healthcare systems that support the social health related needs of individuals as well. And that work is currently happening at Maine Care. And so that's what I want to talk a little bit about next. So here's my promised slide about our rate system reform. So I will share that we have had conversations with managed care organizations where those MCOs specifically said, oh, we're so glad that you're doing an evaluation of your rate system and that you're looking to invest in rates, because we worry about entering into states where that work has not been done, because that creates more risk for the managed care organizations in terms of whether they can have adequate networks and their ability to ensure member access. So as everybody, I hope, is aware, at this point, almost a year ago now, we wrapped up our rate system evaluation for Maine Care. We found that our system is inconsistent. It is oftentimes irrational in terms of the rates that result. We also did an evaluation that showed that there was a clear need for investment in many areas of the system, and that there needs to be a goal of equity to make sure that all of the members that benefit from Maine Care can access the services that they need. Thanks to the down payment in the biennial budget that was passed by you all and the legislature as a whole, we have begun acting on the recommendations of that evaluation, and we have our own plan for rate system reform that is rolling out right now. We are making substantial targeted investments in services as we speak. We are working on rolling out additional rate studies, and I am very excited about LD 1867, which I thank members of this committee for their support so far on that bill, where we're really putting into law what our system needs to look like for setting rates in terms of process, in terms of engagement with stakeholders and with experts, to make sure that we're setting a really strong foundation so that we're not just making sure that we're investing in services now, but that we're investing in a structure so that we can say with confidence that we know that our rates of reimbursement will be what they need to be to ensure that efficiency, economy, and quality of care and the access to services that our members deserve. Another piece that MaineCare has been working on very actively is transitioning to alternative payment models. So I said that states across the country, regardless of whether they are managed care states, are recognizing that there needs to be work to transition to alternative payment models. We, as a department, we announced a while ago now that MaineCare's goal is to have 40% of our reimbursement tied to value by the end of 2022. And I am very proud to announce that we are making fantastic progress on that goal. So our last measurement, which looked at 2020, we always have that claims lag that we need to deal with to be able to measure all the numbers accurately. But by the end of 2020, we were at 36%. So that means that we have 2021 and 2022 to make additional progress towards that 40%, and I'm very confident that we will do so. A big piece of the progress we've been able to make on alternative payment models has been with our Accountable Communities Initiative, which is our version of an accountable care organization, where the accountable communities entities are responsible for the population that receives primary care through their affiliated primary care practices. And if those entities are able to achieve savings as compared to projections on what we think they're going to cost, then they can share in those savings depending on how well they do on quality measures. So we now have 110,000 lives in our Accountable Communities Initiative, and we have produced over 40 million in savings against those projections over 6 years. And the accountable communities have been able to share in those savings proportional to their performance on quality outcomes. We are also in conversations to nail down our glide path, we are calling it, to have accountable communities transition to downside risk. And so that means that those accountable communities will begin taking on some of that risk, sharing that risk with the state, and taking on increased accountability, which is similar to what managed care entities themselves do, and these other models in other states where ACOs take on risk themselves or may partner with a health plan in order to do so. I also wanted to note that we have a proposed rule right now, so I don't think I'm allowed to take questions about Primary Care Plus, but we are rolling out our PC Plus program, which is a comprehensive primary care program. It's recognized as an aligned payer by CMS for CMS's multi-payer primary care first program. And that program will be intentionally also on a path to transition away from fee-for-service payment over time, starting with explicitly linking payment to performance. That model also provides a sustainable model for supporting community health workers, which we think is a really critical step to making sure that we are ensuring equity of services across all of our populations. And the last thing I just wanted to mention is that, so as I mentioned earlier, I was last at MaineCare around 2011, and I had the pleasure of starting up our Accountable Communities program and our primary care reform efforts at that point. And I just want to say that it's been really heartening that the tenor of the conversation in the state has really changed. Now, when we participate in conversations with providers and systems across the state, there is so much support for alternative payment models, and including among some, I'm not going to say among all, but discussion of capitation and acknowledgement that the flexibility that comes with those capitated models are of interest to certain parties. And so I am feeling optimistic about the direction that we're headed as a state in terms of increased accountability, shared accountability between the state and providers. So this is my last slide. I just wanted to briefly mention a number of other main care efforts that are also tied in with our focus on provision of high value care. Obviously, there's been a huge focus over the past couple of years now on supporting providers through COVID. We have initiatives, as does the Office for Family Independence, on improving our member outreach and communications. That means making our systems easier to use. It means having more effective means of communication other than getting a letter in the mail. Everybody uses phones and texts and email, obviously, so we're getting better and more flexible there. We also want to have more targeted outreach that is relevant, culturally relevant as well, and accessible in terms of plain language and languages other than English. And so those are all efforts we're working on around communication. Tied up with those efforts around member communication is prioritization of stakeholder engagement. We've rebuilt a lot of those systems and are proud of the work that we're doing to collaborate with community members, advocates, providers, and members. I also want to note that we have specifically been working with health plans in the state who serve our dual eligible special needs populations. Those plans are often called DSNPs. And to be honest, the state really, even though while we had those contracts officially, we really weren't doing anything with them. And so that has changed. The Office of Aging and Disability Services and Main Care have been working very closely together to establish relationships with those DSNPs, to have expectations for the partnerships that they have in order to integrate care coordination functions with attention to members' physical health needs, and also that they are taking advantage of the resources we have in the state in terms of our health information exchange and being able to access information to help them better manage members' care. And then lastly, we are rolling out adult dental. I will say that there was initial interest in potentially doing that under a managed care model, but given the expectation for rolling that benefit out within a year, it's just not something where we didn't have sufficient time to be able to roll out managed care in that time frame, but we are still interested in that potential. And then lastly, our pharmacy benefits manager, we have a model that basically we are paying the administrative costs per member, per month fee for our pharmacy benefits administration. But it's not the black box kind of model that we've heard about over the past number of years where you're not really sure where the money is going. And I would just note that the model that Main Care has for pharmacy is really the same kind of pass-through model that Senator Sanborn had sponsored legislation that passed a few years ago. And that's the model that the State Employee Health Commission has recently adopted as well. And so while most states include pharmacy in managed care, because of the concern around specialty costs and the lack of transparency in the system, I'd say in the past, probably 6 years or so, there are 8 states who have already carved out pharmacy from their managed care, or they are in the process of doing so. So that is something I wanted to mention to folks as well. All right, so I probably went a little bit long, but thank you for listening and happy to take questions.
I see a question from Representative Zager.
Thank you so much, Mr. Chair. And Director Probert, thank you very much. As always, really educational. My question is regarding the April 2020 annual review of public health study that the meta-analysis that you discussed. I was wondering if it or if you're aware of any other common threads or common features of the successes or of the failures. I think of like a baseball team that wins some and loses some. That doesn't mean that they ought not to play baseball, but maybe learn from from both the successes and the failures. So any discussion in the literature or among main Medicaid directors that you know of?
So first, I will admit that I have not read the whole comprehensive literature review myself, but I think the most common theme is that states have found that making sure that they have that strong contract oversight and that they're holding the managed care plans accountable for outcomes is a consistent theme. I think that's the main finding I would speak to. Olivia, I'll give you the option to chime in if you have any additional information on that.
I would only add, I think that just in addition to the contract oversight and what are you actually holding them accountable for, is do you have the systems infrastructure to support that? So personnel as well as IT systems that work as intended, to make sure that it's allowing members and providers and plans to administer the programs.
Representative Craven.
Thank you, Mr. Chair. This is really an aside question because I had a constituent that asked about it the other day, but I'm interested in the reimbursement for our dental coverage and if providers are actually taking advantage of that. And if we had managed care, is this a benefit that would be included in the managed care provision as well?
So first, I will say that it is up to the state whether or not to incorporate dental benefits into managed care. So sometimes it's carved out and done separately. There are some states that have specific managed care entities just for dental, and so you can do it how you want to do it. So there's variation there. Just as a reminder, so we are effective July 1, as we're rolling out the adult dental benefit, we are going to be benchmarking our main care rates against Maine's commercial rates. So we just received the updated analysis on Maine's commercial dental rates by the Maine Health Data Organization, and we are running those numbers right now to determine what those rates be, but there will be substantial increases for our rates for dental care starting in July.
Thank you.
Director Probert, what's the timeline for getting to, assuming 1867 passes, what's the timeline for getting to a stable process for rate renewal such that you could do reliable actuary analysis?
Yeah, so I'll divide that into two. One is having the process set up, and then two is making our way through all the services that haven't received rate updates in a while. So those are two different things. I think in terms of having our process and structure set up, we are well on our way. And if we have passage of LD 1867, I would say within 6 months, we can have our system in place. We are building that right now, given the legislature's support. Thank you for additional resources that the Office of Main Care Services requires to do all this rate system work. Was there a second part of your question that I missed, or was that?
No, one was the process and one was the getting through all the rate changes as you outlined.
Okay, and getting through the rate changes. So we are working right now to finalize our rate schedule so that we would be able to publish, like, these are the services that are scheduled for rate studies over this period of time. So I believe that at this point, it is going to be a 3 to 4 year process to get through everything.
Okay, thank you for that. I appreciate it. Are there any other questions of Director Probert? There's lots of information. So at some point, maybe Molly can get us some information about what percentage of fraud is still an issue in a main care. I'm looking for places where money can be saved. And if pharmacy benefits now is basically a contracted service and not a black box with unpredictable costs, that's one place where you can't save as much money as you might otherwise have been able to. And I wonder if fraud prevention, what the potential for recovery there is.
We would be happy to pull together information on MaineCare's efforts in that regards.
Thank you. Thank you. Are there any other questions for Director Probert? I'm not seeing any. So thank you for the time. Thank you for the mention of rates. It would have felt awkward if without, would have felt unfamiliar. And we'll look forward to talking to you about 1867 when it hits the agenda.
Great, thank you very much. Nice to see you all.
At this point, we have a number of folks who are available to further educate us. I think Sarah Vanderwood has worked with Anna to set up the process. And so we can invite Joe Mosier, Joe Stephen, and Lisa Allen in to join us. And is that the order in which you'd like to have folks present? Very good. All right. So while Karen is doing that and people go through the wormhole, keep thinking of any questions you'd like to ask. So we'll wait till everybody's here and then we can start. So it looks like we've been joined by Joe Mosier, John Stephen, and Lisa Allen. Welcome to all of you. Thank you for taking the time out of your day to help educate us a bit more about managed care in the main care world. Is there anything you wanted to say, Sarah? Okay, so then we'll just begin right away with Joe Mosier. Welcome.
Yes, thank you, Mr. Chairman and members of the committee. Can you hear me?
We can.
Okay, fantastic. I have a presentation to share with you, so let me share my screen here. Okay, hopefully you can all see that.
We can.
Terrific. Yes, my name is Joe Mosier. I'm a principal in the Indianapolis office of Health Management Associates. I was Medicaid director in Indiana from 2013 to 2017. I implemented a new Medicaid managed care program using MCOs for the aged, blind, and disabled population in Indiana. And I was also Medicaid director when Indiana expanded Medicaid in 2015 and enrolled our Medicaid expansion population into 3 MCOs that existed in the state. Health Management Associates is a nationwide research and consulting firm with offices around the country. We are independent and nonpartisan in the research that we do. We work with state clients, we work with federal agencies, we also work with private sector clients. And in our work with some of our state clients, we recognize the need to do some additional research in some targeted areas around the different models in Medicaid. So today I'm going to talk about 2 research reports that HMA has recently done in the area of Medicaid managed care. The first one involves this question around quality. and if there are differences in the three primary Medicaid delivery models in quality outcomes. So this was one of the key questions that Director Probert mentioned in her remarks, really this lack of evidence around quality differences between MCOs, fee-for-service, and primary care case management. We started this research in December of 2020, and so really was not sure what the results were going to show us when we set out to do this research. Our report is available on our website, and I think a link to it has been circulated to the committee. So very briefly on our methodology, we used a data set called the Medicaid Adult and Child Core Set. It's maintained by CMS and reported by states. It includes 59 measures and includes data from all of the models. So the data is reported the same way, regardless of whether states have MCOs, fee-for-service, or primary care case management. So it really allows for an apples to apples comparison between the models. It's a data set that states have been reporting on since about 2012, but more states are reporting every year. So the richness of the data set is greater now than ever before, and really allows for a meaningful comparison between the models that hasn't been possible really before now. So the data that we used was from 2019. It was the latest available data set. Since then, CMS has now posted data for 2020. So our analysis looks specifically at the 2019 data set. We normalized the data based on which model each state had. So some states have more than one model. For instance, Maine has both fee-for-service and primary care case management. Some states have all three models, fee-for-service, MCOs, and PCCM. So we weighted the data according to the prevalence of that model in each state, and then applied those weights to the outcomes that were reported on each of the measures. 10 measures didn't have enough data in the data set to meaningfully make differences between the models, but we were able to make conclusions based on 49 of the measures. We further divided the measures into 4 domains based on women's health, disease management, behavioral health, and preventive health. And then we assigned a points system. So the model that finished the best on each measure, we gave 3 points. The model that was second best received 2 points, and the model that was the worst or the third best received 1 point. And then we tallied up the points for each measure to determine, which model in each measure performed the best. So here were the results. The data set is divided into child and adult measures. So these are measures like on asthma management, diabetes management, behavioral health, outcomes like follow-up after a hospitalization, a follow-up after 7 days of an inpatient hospitalization for a behavioral health matter, or a follow-up after 30 days. Just some examples of the 49 measures that we looked at. For the child measures, MCOs performed the best and scored the highest in our point system, 51 for the MCO model, 40 for the fee-for-service model, and 35 for primary care case management. And then on the adult measures, managed care organizations also performed better than the other 2 models for a combined point total of 118 for MCOs, 95 for fee-for-service, and 75 for primary care case management. And I mentioned that we further parse the data into these major domain sets based around certain areas of healthcare, preventive care. The MCO model slightly outperformed primary care case management, and both significantly outperformed fee-for-service. On women's health, the MCOs performed better. disease management, the MCOs perform better, and on behavioral health, the MCOs perform better. Some of the key findings, therefore, from this research: Medicaid managed care organizations, programs with MCOs delivered higher performance on quality indicators compared to fee-for-service and PCCM on the 19 core data set. The MCOs are incentivized to make investments into infrastructure, clinical data, capture techniques, value-based contracting arrangements, member and provider incentive programs, and population health stratifications and proactive member engagement strategies. Therefore, it may be a better use of state time and resources to outsource these functions to health plans who specialize in these areas and bring their years of experience, specific expertise, financial imperatives, and process improvement methodologies to bear. Finally, that they're achieving higher quality requires strong alignment and collaboration between the state Medicaid agency, the state regulators, the MCO plans, and providers that are participating in the program. I just want to very briefly talk about the second study that we released in December. So this was a report that we did commissioned by the Together for Better Medicaid group, and it looked at 10 of the recent RFPs from 2020 and 2021 on their requirements around social determinants of health and health equity for their managed care plans. So these, we looked at specifically 10 requests for proposals in states that have MCOs, and we're asking MCOs to respond to their RFPs. This report is available on the Together for Better Medicaid website. And so some key findings from this report, we found that states have the flexibility with the MCO model to provide services that are not otherwise allowed in fee-for-service, including value-added benefits. So these are things like gym memberships and backpacks for kids at school that are in the child welfare population, for instance. They also provide housing, employment, nutrition services, and supports that are not allowed to be covered in traditional Medicaid. And the MCO states are taking advantage of this additional flexibility. States are requiring their MCOs to work with their network providers to screen providers for social determinants of health needs, and then to make the referrals to community-based organizations. And then many are also requiring their MCOs or their network providers to follow up on the outcomes of those referrals to see what happened when they referred members to those community-based organizations. So this is an example of a closed loop referral system for social determinants of health needs, social needs. Many states with MCOs have found it more convenient to leverage the contracts they have with their MCOs to require them to do this rather than to build it themselves, a closed loop referral system. And then finally, recent RFPs also required MCOs to address health equity by training their staff and their network providers on racial and ethnic disparities, cultural competency, diversity, and inclusion. And a few states have incorporated these health equity principles into the MCO payment or provider payment models. So that concludes my remarks. I'm happy to take any questions the committee may have.
Can you speak to provider and patient satisfaction, how that's measured in the current model or assessed in MCOs, and how that might compare with other systems?
Sure. Yeah, we did not look specifically at patient satisfaction in our either of the studies that I referenced. Typically the MCOs are required to do provider satisfaction surveys annually. That can be a contractual requirement. We see that very commonly in state Medicaid MCO programs. And then they're required to make changes, based on their operations according to the results of those surveys. And some states require those survey results to be shared with the states. Same with member satisfaction surveys. Some states also independently do member satisfaction surveys around their MCO plans that help direct state resources and attention to problems that may exist or areas that could be improved.
Thank you. Representative Craven?
Oh, thank you, Mr. Chair. I was wondering what you might be including for the social determinants of health that ordinary Medicaid wouldn't be able to include, like, I don't know, transportation to the supermarket?
Sure. Yeah. So that is supermarket. May or may not be a great example, but the health plans are able to provide transportation beyond what is otherwise approved in a Medicaid state plan. If there, for instance, if there is a stop to a non-healthcare related service like a supermarket or wherever, those are typically not allowed to be paid for in a Medicaid state plan program. An MCO could pay for that, and they can pay for extra transports if there's a cap on the state's transportation benefit, which we often see. And Medicaid, the federal government generally limits payment to state Medicaid agencies around only supports for these social determinants of health, like housing, nutrition, and things of that nature. Whereas the health plans can actually pay for, some of the housing, like a first month's rent, for instance, or things that go beyond what the federal government allows.
Representative Perry?
Thank you. Two things. First of all, you had mentioned the ability to get onto the site for the study. I don't know the link to get in there. If you could put that on chat, I would appreciate it. And also, looking at the flexibility of the ability to work with MCOs in terms of what the state is looking for. Does that negotiation in the changes, is that able to occur during a contract, that those changes can be made, or does that have to wait until the end of the contract?
Okay, so we work with a lot of states in design of their Medicaid managed care programs and then in the RFP process to select vendors. So typically a state will design the program to achieve the goals that they want and that are the most critical to the state. So if you have some population health issues, maybe it's infant mortality, or maybe it's diabetes, or even other birth outcomes issues, you may want to emphasize those. So you design your MCO contracts to improve the areas that are most in need from an individual state perspective. And then those contracts are included in the RFP process. So the health plans responding to them know what they're responding to and what the state priorities are. We find that these contracts are very individualized based on the needs of individual states. There are some federal requirements that are uniform throughout the program, but there's a great deal of state flexibility for each state to design the contracts in the way that they need to achieve the outcomes that they want. And those happen up front. They don't happen, after the fact. If the health plans, want to negotiate in some very targeted areas, some states allow that, and some back and forth with the health plans around, the operations of how certain things are done. But your priorities would be, outlined up front in the contract requirements.
Just one more question. And what is the usual length of a contract, and looked at in terms of renewal as well?
Also very individual based on state procurement laws. So they generally follow, procurement laws that the state has in their Medicaid agency or that is established by legislation. It is, probably most common for a 3 to 4 year contract duration on a base contract with some optional extension periods, maybe an optional 1 year extension or 2 optional 1 year extensions or 1 optional 2 year extension, something like that. But really, a health plan, these MCOs need multiple years of a commitment from a state in order to make the investments into the resources into that state to have the best outcomes.
Representative Stover.
Thank you, Mr. Mosier. You had mentioned earlier that there were states where the MCOs are required to work on the social determinants of health. And I'm just wondering if you have any of those particular states, in addition to the report, any of those states that you would see as being sort of ahead of or sort of on the road of excellence around doing some of that work that we could look at.
Yes, I can certainly put together a list of what we think are states that have best practices in that area. The 10 states that we looked at are mentioned in the study. They were recent RFP states, I believe Minnesota, Louisiana, Kentucky, were some of them, Nevada. But we can put together a list of the states that we think have the best practices in that area for you.
Thank you. I can also look in the report, but that would be helpful.
Representative Lemelin.
Yes, thank you, Senator. Did you indicate that it is more cost effective to contract this service rather than use in-house resources?
So we didn't specifically look at cost savings in this study. There are other studies that speak to the cost efficiency and cost savings that states have achieved through MCO programs. Our study didn't specifically look at that, but based on the quality measures that we looked at, we did conclude that it may be a better use of state resources to contract with these health plans rather than do it internally because of the experience and tools that they have and the flexibilities that they have that aren't available to a fee-for-service program. So that was one of our key findings. It may be a better use of state resources to contract with these third parties.
Did you also say that it helps with rent?
The health plans would have the flexibility to cover things in very individualized circumstances. So, if there were disabled individuals, for instance, that had a problem with maintaining their rent from month to month because of some temporary expense they had or something, for instance, health plans are able to cover those types of things, whereas a state Medicaid agency is not. They'd have to use their own quote profits or resources to do that, but that is not uncommon.
Okay, thank you.
Representative Sager.
Thank you, Mr. Chair. Thank you very much for the report and the presentation, Mr. Mosier. So HMA, I understand, is a leader in consulting on publicly funded healthcare. I may have missed. How did this report get funded?
Sure. So this was part of the work that HMA does to inform our clients on best practices across Medicaid programs. So it is funded from resources the firm has to put together the research that we do for our state clients.
Okay, thank you.
Are there any other questions of Mr. Mosier? I don't see any. So again, thank you for taking time to join us this morning and provide this perspective.
Absolutely. Thank you.
And now we can go to John Stephen. Welcome, sir.
Thank you, Mr. Chairman. I'll share the screen now. So present mode. Okay, well, that's not going to work. Anyways, can everybody hear me okay?
Yes.
Thank you, Mr. Chairman. My name is John Stephen, and I am the managing partner of the Stephen Group. I own a consulting practice in New Hampshire, and I'm going to talk to you today about some of the experiences we have nationally as a consulting firm, but also based on the state of New Hampshire's experience. So I was the former Assistant Attorney General, Deputy Commissioner of Public Safety, and also Commissioner of DHHS, where I ran the Medicaid program in New Hampshire from 2003 to 2007. And in my consulting practice, since I've started in 2010, we have been helping a number of states implement programs like managed care. We have made recommendations. We have national experts. I have consultants that were former commissioners like myself, and we focus a lot on health and human services. So a lot of the social determinant of health questions that are coming up, we really focus a lot on innovation in that area as well. And so we know a lot about those 38 or 39 plus states that have managed care. Some of them we've actually helped, and we've actually helped them improve their statutes and help them write RFPs that have gone out for bid. So I want to help the committee in any way, and I've provided some documents for your assistance going forward. And one of them I'd like to talk about is the next part of my presentation would be really to let you all know that in 2012, as a consultant, my team did some research for Maine Task Force, actually, and that redesigned task force was looking at the very same questions and issues you guys are looking at today. And we came and testified, and we offered a position paper. And I think we at the very end, we said, now is the time for action. I can remember that. So it's before you. There's all kinds of data in there we looked at. And we basically, in a nutshell, and Representative Perry's question originally to Ms. Probert was a great question, because we saw that in Maine, the high cost populations were really much more higher than any state in the country. In fact, we saw some areas in the development disability area where you were spending on your waiver programs, probably highest in the nation. You were somewhere around 85,000 per recipient, I remember, and the national average was like 45,000. And so we started to focus on some of those high cost long-term care populations. And in the testimony, you'll see there are recommendations to really start to look at how can you try to bring those costs under control, as well as promote greater quality. And we offered what was, just I would say a hybrid of the capitated full risk managed care model that you heard today. And we had talked about some of these recommendations to at least bring the beginning of more management, effective management to those high costs. And I used my experience as commissioner in New Hampshire, controlling Medicaid costs, and really knowing that in best practices moving forward, states were moving to the fully capitated managed care risk-based systems. Next slide. Prior to this, time, I also want to make sure that in New Hampshire, what we did to really start managed care and implement managed care. Now, as commissioner, I was not part of the implementation of managed care. When I was a commissioner between 2003 and 2007, we had most of our children and moms and kids were in a voluntary managed care health plan program where they elected to move into that program, and it was run very well. And there were outcomes, but there was, again, that high cost case issue always would come to my desk, and I'd figure, what are we doing to help that individual? And my staff could not manage those cases as well as some of these types of companies and managed care and administrative support services. So for example, in Maine today, the senior that has chronic illness, that's on the verge of going to a nursing home, that just needs some additional care coordination, some help in the community, making sure someone's checking on them regularly, making sure that they're doing everything they can. That's the type of support a managed care company brings, because their incentive is to make sure those costs are controlled. They don't want that senior to move into a higher cost setting. The state, in at least my example, they will just go to the next legislative session and ask for more money. The companies have an incentive to make sure that they don't have that situation happen. And then quality is controlled through the contract management process. So I wanted to make sure that you knew at least New Hampshire started down the road of what we call the high cost enhanced care management coordination. But in 2011, I was asked to help the legislature draft the law that became the managed care law in New Hampshire and your neighboring state. It was passed in 2011 and it was implemented beginning in 2013. And what I'm going to do now, I'm going to run through this quickly, but there's a number of slides I put in my presentation, members of the committees, that will help you just to get acclimated to understand the New Hampshire Managed Care Program. It's a capitated full risk program since 2014 or the end of 13. And what Joe had mentioned in his presentation, all those issues have really come to bear to fruition in New Hampshire, where there's more management, control, and focus on quality and on keeping costs under control as well, which is important to the taxpayers. In 2017, the New Hampshire expansion population went from the health exchange private health plans into Medicaid managed care. So now, today, you have over about 180,000 recipients in managed care in New Hampshire. And this will just give you an example of the 3 plans or 3 health plans. Some of the statutes specifically address a number of health plans, 3 or less. You want to, at least in Maine, and I said this in my help with the legislature, you definitely want to look at least 3 for your population based, in my opinion, because there's risk stratification that needs to be taken into consideration for those plans. You want the national plans to come in, but you also want to allow for, plans that could really innovate and are Medicaid only and focus on the population. The next slide is really, this is an opportunity to give you a snapshot of where we are today in New Hampshire. The number of lives, the cost, and then the next few slides are slides that the Department of Health and Human Services presented to the legislature recently. In this slide, you can see substantial amount of the Medicaid beneficiaries are in Medicaid managed care capitated full risk with 3 health plans today. And this just gives you, again, background on the dollars, the number of enrollees. And I thought this was a good slide too, that gives you this is what the New Hampshire commissioner presented to the legislature during the last budget session. And it was just a general overview of all the benefits of managed care. I do want to add to the committee, I think the very important document I attached for you all is this, you'll see this, not spreadsheet, but it's a Word document with columns, and it has about 7 or 8 Medicaid managed care plans that were interviewed by my staff in Arkansas. We were hired by the legislature, bipartisan legislative committee like yourselves, to offer recommendations for them on where Arkansas should move forward on. And we were asked to interview all of the Medicaid managed care, the big national players at the time. And they all were very willing, and they gave us basically their playbook on all different areas of care coordination, patient utilization, management controls. And I think that's going to be very helpful for the committee going forward. This is a really good slide because it shows in the managed care program in New Hampshire, if you look at well child visits, it's comparing commercial health insurance to Medicaid managed care plans, and also the regular Medicaid national market. New Hampshire, I would want to make sure New Hampshire is higher than the national market for sure. But you can see commercial plans a little higher in child well visits, but breast cancer screening, the Medicaid managed care plans have done a better job. Diabetes control, you can see Medicaid managed care in New Hampshire is, in my opinion, working. And there are things that they do every year. And I want to say that Ms. Probert's testimony regarding the pandemic and not having the requisite controls, I do want to make sure to clarify in New Hampshire, during the pandemic, the state of New Hampshire actually, because they had it in the contract, brought all the 3 plans in and reduced the contract. In one of the presentations they recently gave to the legislature, they actually were able to recoup $128 million from the 3 plans They reduced the cap rate by 3% because ER admissions had gone down and they knew that ahead of time. So again, everything is about what you put in that contract, in my opinion, and how you as a state manage a contract. What you're doing is shifting from managing a program, which I never, in my opinion as commissioner, wanted my staff to manage. I wanted the private sector to manage because they knew how, they knew the best practices, they could move quickly. But now I wanted to be able to manage that contract. And that's where the real big difference is. Here in New Hampshire, I think this is a really important slide, and I'm coming to the end of my presentation. This shows you the national quality standards that have to be at least compared in every state that has any program of managed care. And you can see in all of the key areas, network adequacy, standards for practitioners, all the key NCQA standards were met by the New Hampshire managed care plans. This was in 2017. That's the most recent, and that has not changed based on the most recent presentation during the last budget session. I saw this quote from Milliman, who's doing our rate analysis here in New Hampshire, where the costs have really been kept under the projected costs. There would need to be additional research to look at budget neutrality over the years, and I was unable to find that for you, but there's no indication here in New Hampshire that the costs would be much more or more than fee-for-service. Fee-for-service costs would have been a lot more than where they are today if we continued on fee-for-service. This final slide, again, and this goes back to the social determinants of health. And I just wanted the committee to see this. I thought it was important. In 2017, when they were writing the RFP for the next round in New Hampshire RFPs, they had provisions about social determinants of health in the contract. They required the 3 plans with social determinants of health to what they call basically close the loop. We had a mental health, we still have a mental health issue in New Hampshire with ER boarding, and we had a crisis there was a lawsuit that occurred a number of years ago. There was issues of mental health, and we have no institutions in New Hampshire. We have an acute care hospital, but really there was an agreement, a settlement agreement. And in 2017, the commissioner, as part of that agreement, put in a requirement in the contract that all the plans now have to work from the discharge to the hospital to connection to the practitioner in the community, and then closing the loop to make sure the patient actually got the service. And what I really like about the contract provision here is it not only applies to physical and psychiatric care, it applies to social determinants of health. You need food, you need transportation to the grocery store. They are required now to report on that. This is something you can do in the contract. And that's why it's so critical when you look at this and move down in this area, that the state contract really make sure you ensure the provisions that you need to meet your priorities in there, as well as accountability. And that's about all I have right now, Mr. Chairman. I'd be happy to answer any questions, and thank you for this opportunity. Mr. Chairman, you're on mute.
My non-scheduled technical difficulty. Representative Craven.
Thank you, Mr. Chair. Thank you, Mr. Stevens. You sound very enthusiastic, and I'm not. I'm
just a passionate guy.
Well, I do have a concern about your depiction of services for ID and DD populations, because as I understand it, staffing takes up 90% or more of the costs of those services. And it's not just the state of Maine that's in a staffing crisis and are definitely lowballed here for our drug care workers, and just wonder what you have to say about having that be so high in Maine besides other states.
Representative, it's a great question. When I looked at the data in 2012, I think it was my impression, and we looked at it, and I'm going back on memory, it was so substantially more than the national average. And I think it had to do with the number of individuals in the IDD system in Maine that are in group homes, that are in residential care, versus the number in most of the other states that are in home and community-based, less expensive placements. And so if you look at that, when I started to review the states, I saw Texas and a few others that were close to Maine, and every one of those states had high focus on group homes and residential care. And so, but I want to make sure that I leave you with this on this issue. It's up to the committee to suggest what populations go into managed care. In New Hampshire, the waiver population stayed out of managed care, but the acute care for those populations were covered. If I'm in a development disability group home and I have a chronic illness or a behavioral health crisis, which happens a lot, and I have my care manager bringing me to an ER or a caretaker managing that population, and I don't have a managed care manager that is watching that closely, that I can make sure connects upon discharge, does all that. My point is, I would rather have a health plan that does this for a living, working on the acute care of those populations that need help the most, than having the state workers working to manage that. There is so much going on that they have to worry about as well. And I just don't see it as the same. And as commissioner, and then as consultant now, it's clear to me that system is best. And so I just want to make sure I clarified that on the DD waiver side. It's really the acute care that I wanted you to focus on.
Are there other questions, Mr. Stephen? Mine is basically an understanding that each state is different. Where does the money come from that turns into savings and that pays for the MCO contract? Where are some of the buckets where savings can possibly be found, depending on state priorities and state circumstances? You just mentioned the IDD community and acute care. Where else is that money coming from?
So again, when you look at a managed care program, you need to go to CMS and receive approval of a waiver to move forward in this direction. Every Section 1115 waivers, at least when I was there in New Hampshire working on it, require what's called, Mr. Chairman, budget neutrality. So you have to do your actuarial assessment. You have to then be able to show the federal government that the cost of care going forward for the next 5 years without managed care, staying at fee-for-service, is going to grow at this certain amount. And you look at your prior growth and you make estimates. If we have managed care, let's say that's 8% in Maine a year. If we bring in a capitated full risk managed care system, we think it's going to grow at 4% a year. After a period of time, a 5-year usually is the waiver, there will be a certain amount of savings. And in one state that I worked on a waiver, we were able to show CMS that there was going to be about $2 billion less from the fee-for-service line with the waiver. And they allowed us to even use some of those dollars year by year to keep seniors healthy and in the community going forward. But that's all dependent on those negotiations. Does that help you answer that question?
It does. Yes, it does. Thank you. The other question is a sort of a follow-up to Representative Craven's, and it's about capacity. I think I read somewhere as I went through this material that in the initiation of a Medicare contract, there has to be some sort of capacity assessment. We on HHS are feeling that we have none for anything. And so how do you deal with that as you begin to try and put together a managed care contract?
This is a really great question. So there's readiness review that's required. So let's say the department were to issue an RFP, and then there was a response to the RFP, and they picked their winners. At that point, it's usually, sometimes it could be up 6 months less to maybe a year of what they call readiness review. That is where the state and they usually hire out services, will begin to ask those kind of questions that you ask. Who is in your network? Where is your network? Do you meet certain network capacity issues? Also, what type of network you have. And there's a checklist, and there's readiness review that is you can look at Tennessee and some of the most recent ones that we helped in Arkansas actually develop the readiness criteria for them. It's very, very complex, thorough. And so the state then will make sure that every one of those boxes are checked before they go back to CMS and say, now we're ready to go forward. And that's where that capacity will be looked at, Mr. Chairman. And the managed care entities will not get a contract started unless they meet that criteria. And they have to show that actually on the ground. And that's what they're good at. They're good at building networks, but then they got to begin to negotiate rates with providers.
Mhm.
And sometimes managed care companies will go into a hospital and say, look, I understand the Medicaid rate is here. We're going to give you the Medicaid rate, but we're also going to pay you here. Again, what Michelle said about value, as long as you meet all these value criteria. Because in the end, that will result in savings to the plan,
Sure.
and the contract will allow money to be given back to the state if it's written the right way.
Okay. Thank you for that. I appreciate that information. Representative Lemlin?
Yes, thank you, Senator. What's the difference between this and a person having a case manager?
I mean, it's, again, a great question. A case manager has to work for some entity. Either they're working for the state, they're working for an independent organization, or they're working for a health plan. And so you really need representative of a case manager no matter what. In the IDD system where we talked about, there's definite need for a case manager to make sure that there's actual coordination of effective services. So that is, in some of it's Medicaid allowable. And so whether it's the state doing it, an independent entity, or a health plan, you're not changing the need for case management. What you're changing in the managed care world is who is going to be overseeing that case management. Does that help answer your question?
It does. So you're saying that in this type of system, you're indicating to me that the case manager needs somebody overseeing them?
What I'm suggesting is the best results, in my opinion, and I'm not talking so much about the waiver programs, but on the medical side, on the acute care, the best results come when you're looking at holistic care, and the case manager is focusing on making sure the individual gets the best follow-up, wraparound services, connections to behavioral health. And that in my experience, those activities, including social determinants of health, are done best by companies that do that for a living, that also are incentivized the right way in the contract to promote quality and save dollars.
Okay, thank you very much.
So is it fair then to say that when there's an incentive to provide those wraparound services and to all the people in a given population who need them, then there's cost savings to that, and that aligns with the objectives of the MCO?
Absolutely. And again, I was a commissioner for 4 years. I had a great staff. I had 3,000 staff members. I did not believe that my staff had the right incentives that, on the cost savings. They care a lot about the people, they care about the members, but I found little evidence, maybe a few of my staff at the top level, because I'm just going to go to the legislature and testify. And if we need more money, we're going to get more money. And I always found that, that did not rub well with me as being a guy that wanted to make sure also the fiscal side was under control for the taxpayers. That's all.
Thank you. Representative Madigan?
Thank you. Thank you for being here, Mr. Stephen. You made a reference to managing behavioral health. people with behavioral health disorders. I wonder, I have a couple questions about that. Would that also include substance use disorders? And when you talk about holistic health, would that include wrapping a case manager around managing physical, behavioral health, substance use disorder treatment together and making sure that treatment happens?
Representative, it's a great question. Absolutely, unequivocally. But again, I want to make sure the contract is key, the RFP is key, to make sure that there's requirements in there on reporting, holding the plans accountable if they're not doing what you say, because at the end of the day, and again, I would recommend, if I was writing this RFP, if you move in this direction, really focusing on that holistic care that you're talking about. Because if you just have intervention on the behavioral health side, and you're not looking at what else is going on in that home, and there's other areas that need help, you're not addressing the whole problem. And you're going to end up having someone come back into a rehabilitation psych facility or whatever. So your question, I would rather have a health plan that knows how to do that for a living, that has good outcomes, with a great department that can hold them accountable. To me, that's the best system of care.
A follow-up question?
Sure.
So Medicare often, Medicare, of course, tracks rehospitalizations after 30 days. And, providers, you're supposed to make sure that doesn't happen.
Mm-hmm.
I mean, that could certainly be an outcome that is tracked, that is put in a contract. We could certainly put into a contract that follow-up appointments are kept, or that level of care kind of matches what the assessed need is for. Are those the kind of things that you would suggest be in a plan like that? Like the outcome, the metrics you put in a contract like that?
Absolutely, part of them. But then there's a lot of NCQA metrics we talked about, network adequacies in there. The contract in many of these states sometimes can be 100 pages. And the plans are used to reporting. They know that they're also being compared against their partner companies. They all are good intention, want to meet those key critical quality standards. And what I've seen, at least, they also really want to make sure that the state priorities by the Department of Health and Human Services are met. And so the state sets those priorities, Representative, and they're so critical to make sure you get those priorities out there to the public, out to the stakeholders, listening to the stakeholders, and then develop them in the RFP and then put them in the contract. Yes.
Thank you.
Thank you again, Mr.
Thank you.
Stephen. Before we go to, thank you for being here. Before we go to Lisa Allen, and I see that Kevin Lewis has joined us, I'm going to turn over the chair to Representative Meyer. I need to step away for a 12 o'clock appointment. I apologize to the committee, and but I just wanted to do that officially. Did I see a hand up for Representative Stover before I go?
I don't think so.
That's okay.
Okay.
No.
All right. So thank you for this session, and I'll be back as quickly as I can, but I'm not sure how long that'll be.
Thank you, Senator. I see Mr. Lewis has joined us, and I know that he has some time constraints, and I wonder, Mr. Lewis, if you would like to present next, and if Ms. Allen is okay with that change in the format.
That's fine. That's fine.
Thank you.
I'm totally fine with the schedule as it is. I'm happy to just take the schedule as you had proposed it. So
okay,
no need to make a comment. I guess is what I'm saying.
Thank you. So we would welcome Lisa Allen. You are muted.
I think it's almost afternoon at this point. Let's see, can you see the screen?
We can.
Okay, so thank you for having me to the committee hearing this morning. My name is Lisa Allen, and I am a director with
the Sellers Dorsey National Consulting Practice. Sellers Dorsey is a national consulting firm that specializes in both Medicaid financing as well as consultation services to over 40 states across the nation. And we're delighted to be here this morning with you. Prior to coming to Sellers Dorsey, just a little bit about my background. I spent 26 years with the Commonwealth of Pennsylvania. In my roles there, I was the Medicaid director and also the executive deputy over the Department of Human Services, which is an umbrella agency in Pennsylvania with all human services underneath that. So I'm delighted to be here with you all today. And I would say that one of the first comments that I have is I really applaud you all for taking the time to educate yourselves about a move to managed care, what managed care brings, what fee-for-service offers, what primary care case management offers. I think it's really important to be able to have a full scope of all of the various delivery systems as you're thinking through next steps with your bills here. So I'm going to talk more specifically about my experience in Pennsylvania. And hopefully that will give you a sense of just another state's perspective on this. So from a Pennsylvania perspective, we took about 3 decades to get to different structures of managed care. We started very early on with voluntary managed care in just one area of Pennsylvania, and moved from there into more of a primary care case management program. And that was in the 1990s. The primary care case management program that we operated early on was really focused on kids. And, you know, the timing of that from the 1990s, obviously, that is when the federal government passed the Early Periodic Screening, Diagnosis, and Treatment Program. And a lot of our activities around the primary care case management program were focused on making sure that those children were actually receiving those screening services and getting the follow-up care that they needed. It was a modest primary care case management program. It was really just for those pediatric practices and primary care physicians who were seeing children, had a modest case management fee associated with it, but was really based on a fee-for-service payment structure where the actual service provision was paid off of the Medicaid fee-for-service fee schedule. Similar to what you are doing there in Maine with updating your fees, it was based off of that fee schedule. And then we moved in 1997. We started to think about more comprehensive managed care from the work that we had done on the primary care case management side and our voluntary managed care experience to think about comprehensive managed care for all of our populations. And I will say for Pennsylvania, we included almost all of our populations in our acute physical health managed, and I'm going to call physical health managed care program from the very beginning. In 1997, we started and we moved into our most populous area, which was the southeastern region of Pennsylvania, that purple shade on the map here, to test the waters and see how a mandatory program would actually work for us. So we included, you know, the ABD populations, we included foster children. We actually even included the dual eligibles back in 1997 because we wanted to make sure that if we were moving to full risk managed care, the plans were actually managing our most complex populations, which we knew were a lot of those folks. So we started in 97 and we gradually phased into other areas. And part of that was to give ourselves the experience from the various areas in learning what were the best things, what were the best practices, what were the changes that we needed to make along the way. And we adjusted our contracts accordingly based off of that. And then we moved into the southwest region of Pennsylvania, which is the second, most populous area. And certainly those were our 2 urban areas of Pennsylvania. Pennsylvania has both urban and a lot of rural areas, which we'll talk about at the top of the map there. But that was our expansion, was trying to look at Where were the populations? Where were the services being delivered? We set our map up according to those types of information that we had gathered over a course of time and educating ourselves about patterns of care, where people were going for care, and that's what divided up the regions for us. And so in 1999 and 2001, by 2001, we had implemented it across the bottom part of the Commonwealth, which was both the Southeast, the Southwest, and then the Lehigh Capital Zone, which is like the Lehigh Capital is mainly the Harrisburg area and surrounding counties. And then from there, we got to the more rural areas of Pennsylvania. And how would we make sure that we had both the managed care program that we wanted in that area, that we had the providers who were able to serve their participants. Obviously, in the Medicaid fee-for-service arena, it is always a challenge when you're looking to provide care and make sure that there's access and quality of care. Access is a key fundamental within the Medicaid program. And so we looked at would mandatory managed care make sense for those rural areas? So based off of that review of where things were at the time, we decided to try an enhanced primary care case management program for the rural areas. And we ran that along our voluntary managed care program. So we had the primary care case management program. We had voluntary managed care plans who were offering services in those areas. And through 2005 and 2006, we implemented that across that top layer of our most rural counties. And what we did was we allowed our participants to actually make the choice of whether they wanted to be in the enhanced primary care case management program or in a voluntary managed care program if it was operating in if the plan was operating in their county where they resided. And so if they did not make a choice, we automatically put them into the enhanced primary care case management program. And that gave us an opportunity to test and to see whether or not fully capitated managed care would be beneficial in those areas. What we found was that folks actually, through our work with our consumers and our members across the board, managed care actually provided greater access to some of the providers in those areas. And so by 2012 and 2013, we made the decision to move to full mandatory managed care across those other regions of Pennsylvania and phased out our primary care case management program. I will say the primary care case management program had good outcomes in terms of quality and performance, but there was definitely an opportunity to take that to the next level in terms of more robust care management and payment structures. And then I'll just touch briefly on the fact that in 2018, we finally moved back to having managed care for our aged and physically disabled and dual eligible consumers. So I should step back and say, when Medicare Part D was implemented, we actually pulled the dual eligibles out of our managed care program. What we found at that point in time was that we were managing a lot of the drug costs for those populations, and with Part D coming on, we pulled them out of our physical and behavioral health managed care programs. So in 2018, that's when we made the decision to move back to a managed care approach for our long-term services and supports folks. And that's primarily those long-term services and supports individuals who were in the aged, physically disabled waivers that we were operating, our home and community-based waivers, and then the dual eligibles, those who are eligible for Medicare and Medicaid services. We do not currently have managed care for intellectually disabled populations in Pennsylvania for their waiver services. Those folks are still in our managed care programs for their physical and their behavioral health services, but their home and community-based services are actually still delivered on a fee-for-service basis. Just a few slide based on our experience with managed care and PCCM. The PCCM program was really built around federal and state fee-for-service regulatory and payment structures. CMS does have strict federal rules around managed care, which also include PCCM models, but the managed care provisions are much more comprehensive in terms of the coverage requirements, and therefore the rules are a little bit more stringent in terms of what they're requiring states to do around managed care, full risk managed care. We found that in a PCCM structure, it does, primarily rely on your fee-for-service rates. There's a potential for enhanced payments to offices that, conduct those case management services. There's definitely opportunity for incentives. And I know Director Probert mentioned that you all were moving towards more incentive-based types of activities, but that really is focused on those disease management type activities and medical activities, and not so much on those other types of non-medical issues. The MCO structure is a comprehensive coverage structure. It requires that an MCO cover those services that are the full scope of services, with some exceptions. You can carve out specific services or populations. I think we talked about dental as a question this morning, and potentially starting to see some other states around pharmacy and maybe even some behavioral health services. But in a managed care structure, it's the total cost of the member that really they're accountable for, versus just the other medical type of services that are generally in a PCCM environment. And then, the additional requirements around rate setting, the quality and enrollee communications in a managed care program are much more stringent on the managed care side. I think we talked a little bit this morning. Folks were asking the question about quality and, how do you get that feedback? In many instances, the states are requiring that their managed care plans be accredited by the National Committee on Quality Assurance, which requires them to meet certain thresholds in order to go through that review and receive that rating from the National Committee on Quality. So they do have some other things that they will have to do as far as consumers. They all would then also have to do consumer assessment surveys and give that feedback also. So just a few things around budget and predictability and other things. Managed care plans are definitely driven by actuarially sound capitation rates. It is one of the foundations for managed care. One of the things that I think is pretty interesting about that is that it more closely examines some of your historical data. It also looks at medical trends across the board, program changes that you might be making there in Maine, and then more specifically, expected efficiencies. So there are expected efficiencies that you should require as part of moving to a managed care program. And some of those things are you can set thresholds for. So program efficiencies that can drive quality. In Pennsylvania, we actually worked with our actuary to set targeted efficiency adjustments for things like inpatient admissions, inpatient readmissions, ED visits, expected pharmacy pricing and cost trends, review of high-cost radiology services. So missed opportunities for third-party liability and program integrity efforts. We took those right out of the managed care cost rate base before we even began our rate setting with our plans, because there was an expected level of bringing a commercial insurer into the market, a partner with you, with your expectation that there would be achieved savings from that. We took $1 billion out of the rate base over a 5-year period in our managed care program. And in a fee-for-service environment, you're moving more towards, consideration of what are the Medicare rates, what are the average commercial rates as you set your fee-for-service fee schedule rates, but allowing for those efficiencies, allowing for the fact that the plans can actually pay providers differently. They don't have to pay all providers the same. They can base their arrangements on quality, value, specific populations being served, et cetera, which seems to be, half of the states are also moving more towards value-based purchasing, which is moving folks along the continuum. It's more than just incentivizing providers for, closing gaps in care and reducing certain chronic care measures, but looking more holistically at how you actually address total population health and total cost of care for members, and allows them that flexibility to do so. So there's also, I would say, in terms of scrutiny on the managed care plans, in terms of preventing fraud, waste, and abuse, it's an extra set of arms and eyes on what's happening with providers, with participants, et cetera. States still have ultimately the responsibility to perform those activities alongside their managed care plans, but with strong contract requirements. And again, you can set some efficiency adjustments where your expectation is that the plan would accomplish certain activities associated with fraud, waste, and abuse in order to avoid some of those additional costs. And just some additional, I know that there was a lot of conversation about what other plans can do as far as program innovations, et cetera. In a managed care environment, there are different types of waivers that states can pursue. There was the discussion about an 1115 waiver. There are other, states can do managed care through a state plan amendment now. They can do it through a 1915B waiver, which is, more related to a cost effectiveness test against your fee for service program versus a budget neutrality activity with an 1115 waiver. But it does allow plans, regardless, to offer value-added services or services in lieu of otherwise coverable Medicaid services. So for instance, when we were talking about transportation and rent and those types of things, plans actually can cover those as either value-added services, or if in fact, for instance, your state does not cover eyeglasses, for instance, for an adult participant, plans can offer those services in addition to things that would not otherwise be available. And we saw plans doing that in Pennsylvania. And that was one of the reasons our consumers really embraced the managed care delivery system, both from an access to additional providers, as well as those additional benefits that weren't previously available in our other programs. So that's just a little bit about our experience in Pennsylvania with the way that the program was rolled out. It did allow us to bring, additional innovations in, and really we educated ourselves in the very beginning and took a slow approach to try to understand the various models so that we knew as we moved forward, we had those experiences, we had that to build upon throughout the course. And so I just ended with a slide here on, here's what it currently looks like today. Here is the July 2021. This comes right from the Kaiser Family Foundation website, and it kind of gives you the look at where does managed care stand? Where does fee for service stand? Where are there dual models perhaps, or just a PCCM model? So thank you for the opportunity to share my experiences, and I'm happy to answer any questions.
Thank you, Ms. Allen. Questions from the committee for Ms. Allen? Seeing none. Thank you for being here today. Mr. Lewis. Welcome.
Hey, good afternoon. Thank you so much, Representative Meyer and members of the committee. Let's see, I can share my screen, or I'm not sure if you have something loaded up on your end that I should key off of.
Anna?
It works best.
It's up to you, Kevin. You can share your screen if you like.
Okay, so I don't often do this, so bear with me while I try and get this
If you have trouble, I can give it a whack. There we go.
Let me go to the beginning. Excellent. All right. Thank you. Thank you for your patience in accommodating me. Really pleased to be with you and honored to be in this set of presentations. You've certainly heard from some real experts, and I'm coming on the heels of a robust set of presentations on the nature and opportunity of managed care organizations and what that might mean for Maine should there be a partnership approach that is adopted by MaineCare. What I'm going to do, hopefully over the next few minutes, is introduce or perhaps reintroduce you to Community Health Options. And as mentioned, my name is Kevin Lewis. I'm the CEO of the company. And we are proud to be Maine's nonprofit health plan. We just celebrated our 10th year since establishment, and this is our 9th year of operations. A lot has happened over this past decade, and Health Options has strengthened our capacity and brought to bear successful management programs that benefit our members and benefit our provider network while reducing the total cost of care. So I'd like to share at top level summaries of a few of these efforts as they illustrate examples and bring hopefully onto your radar screen what we're doing locally that could well translate into the MCO model that you've been exploring here today. But first, what I'd like to do is talk a bit about who we are, which is perhaps best captured by our mission and vision, and which is really based on partnership. And in our case, it's to partner locally with our members, with businesses and health professionals, so our network, provide affordable, high-quality benefits that promote health and well-being. And this has really been crafted over the years, and one of the hallmarks or changes that was made a few years ago is to add that last word, well-being, because we firmly believe that if our members don't have a sense of improved well-being, then we're not fulfilling our mission. We're not fulfilling why it is that we came into existence in the first place. And our vision hinges on another key criteria, which is that we have to make a demonstrable impact to the good by way of our local economies. And by that, it's a reflection of the need to reduce the total costs while improving the quality of life, while improving the quality of health outcomes for our members. So our approach, well, I should, before getting to there, I'll just talk a little bit about where we are in the state. And the map on the left gives you a sense of our membership as of January this year. And it tracks pretty well with the statewide distribution of our population, perhaps a little greater concentration in Cumberland County, a little bit of concentration uptick in Oxford County this year, but overall fairly well dispersed. I'll mention that our staffing is also dispersed throughout the state of Maine. We've been remote since the start of the pandemic, and that's offered us greater flexibility in terms of providing jobs to people in different parts of the state that otherwise may have been a little hamstrung in the commute into our headquarters in Lewiston. And so we are proud to offer that flexibility, and also it I think helps with our connection with our membership Our board is a very committed board that also reflects, I think, the state as a whole, and it's elected by the members. So they come from various walks of life and perspectives, and together they form a great group of impassioned and very dedicated volunteer directors. So our approach really does start with data and analysis, and we look at, we start there in terms of identifying the key drivers and those aspects of price and utilization that were talked about earlier, and how we can meaningfully impact them for the benefit of the membership. We work across the various domains in terms of medical management. We have our own in-house pharmacy team that I'll be talking about briefly a little bit later, but includes two very skilled and fantastic pharmacists. And then we have our own local account management, of course, and a member support team that interfaces with members, providers, brokers, really to be the one-stop shop in most cases, managing any issues that come up and interfacing with the entire rest of the company. So what I'd like to do is dig in a little bit in terms of some of the population health management programs, and without going through all of these, but I wanted to provide you sort of a map of how we've structured different programs and engagement with our members. And then what I'd like to do is take about half a dozen of these and dig a little deeper to give you that perspective. So the first of these is an effort to reduce readmissions. And as was talked about earlier, I think it's in everyone's best interest, provider and member alike, to reduce readmissions. And so we identify members that, on the basis of certain diagnoses or experience, qualify for the program. And it really involves that support immediately following discharge to avoid readmission. It includes barrier removal for medications, includes barrier removal for DME, whatever support and follow-up is necessary to make sure that the program, that the community placement is successful, and so that readmission for the same cause doesn't occur. As you can see, we've been very successful in the effort, reducing our readmission rate in half and well below the industry standard. So we're proud to continue on with this, and it's a very dedicated team that focuses on this. For those members that don't qualify for the readmission prevention program, we have another effort that's called Transitions of Care, and similarly deals with removal of barriers, for medications, for DME, making sure people have access to the necessary community-based supports. Another program we have is our point of service program. And this deals also with removing barriers and focuses as well on transportation barriers and works with community partners to assist our members gaining access. And we also look at opportunities in terms of the network. If our members are in an out-of-network situation or needing support out of area, we work to try and find them similar or better supports within the geographic area, within our network. And then if that's not possible, we arrange for single case agreements or other ways to ensure that our members are getting the best and most appropriate care to resolve issues. Again, looking at both the quality of care as well as the total cost of care. Another program we have is called our Site of Care program, and this focuses on those members that are receiving medical-based pharmaceuticals, so often called J-codes or medical pharmacy benefits. These are one of the most expensive elements within, within the provision of care, and there's great opportunity, frankly, in terms of moving members on a voluntary basis to high quality but low cost facilities, provider offices, infusion centers, or even at home. So we have a range of providers in that preferred network of ours. And since we began the program, and again, this is on a voluntary basis, we have saved the membership over $5 million. So that results in reduced premiums, as well as improved satisfaction when you take into account the ease of getting an infusion, for instance, at home. An example of this is a patient member of ours with multiple sclerosis receiving Ocrevus every 6 months. The initial cost was about $117,000 for the year, and we were able to identify a better site of care that improved the convenience, improved satisfaction, and resulted in about a $51,000 savings to the plan over the course of the year. We also engage in outreach efforts. I'll identify a couple of these for asthma and then diabetes, but just quickly, the pilot was really focused on helping our members with the use of their inhalers and improving the management of the disease so that it wasn't resulting in as frequent rescue events. And indeed, the pilot dropped the rescue events by 80%. In the area of diabetes, another outreach effort was able to reduce glucose levels by about a half a point, which is considerable when, of course, we're trying to get control under 7.0 in most cases. So a half a point is a definite improvement. And it involves obtaining meters at no cost and helping our members with that remote monitoring. And then that coupled with our own pharmacy team's adherence program and helping our members make sure that they're getting all of the necessary care, the quarterly visits, the foot checks, the retinopathy exams, and so forth, all necessary to make sure that outcomes are improved. I talked a little bit about our call center and our member services, and something I just wanted to highlight is our dedication to best-in-class service, and certainly our call center is on the front lines of that, but this emanates throughout the company, and we have a dedication to promises delivered on any promise that we make. And we also really take seriously first call resolution. And if we can't resolve it in that first call, then we follow up. So we don't issue homework to our members. We take on the work and route back to the member or the provider to ensure that there's a successful resolution. We're proud of the satisfaction numbers that we've earned thus far, and continue to look at this as a necessary aspect of our engagement with Maine people. We're proud to be accredited and have a 4-star rating, something that we continue to invest in and work on. Knowing that this isn't the only marker of success, but it is an important one. So I'm proud to put that up. And with that, I will stop for any questions that the committee may have. Again, it's an honor to be part of this panel. And, you know, we are among health plans that in the state. I don't suggest that what we're doing is necessarily different or novel, but hopefully it does give you some insights into how we're operating and what we could do by way of a partnership with the Main Care program. Right, and I do list both my email as well as that of Kim Cook. You probably know Kim. She's our very able and great advocate, and her company is Government Strategies. So happy to field your questions now or later as they may occur.
Thank you. Questions from the committee? Seeing no hands raised, we have your contact information and we thank you for being with us today.
Thank you very much, President Meyer.
So with that, and I do believe that concludes the presentations for today. Yes. Anything for us, Anna, before we break for lunch and the potential to return at some point, maybe 2:30?
Okay.
Nothing for us before
No,
we do that?
it's up to you if you have anything that you need. Otherwise,
okay. Does that work for the committee to break at this point and return back at 2:30? Okay, with that, we'll see you then.
Looks like this is pretty much everybody who was here this morning. That being the case, we can go ahead and resume the work session on LD 1701. And actually, what we don't have is Molly, but maybe we can commission Anna to ask Molly if we need to. I don't know if she's in the waiting room, one attendee. No,
She's not, but we can let her know if we need her.
Okay. So where did Representative Perry go? Because she had a question. But I'll ask it for her so we're not all waiting. The question came up was, can we have some sort of roadmap from the department of where they're going over the next 5 years with managed care and alternative payments to give us a sense of what's coming down the road and how well that would overlap with a managed care contract arrangement for main care. Does everybody okay with that? Is there a question to the department? Okay. Yeah. So the trick I hear is that we want to get the advantages of main care and managed care without taking on the problems. And the question is, how close can we get to what we want with what the department has laid out or is thinking about? Because I'm not sure I've seen it laid out. How about other questions or thoughts to go to Anna, to whoever? Yes, Representative Zager.
Thank you, Mr. Chair. I wonder what NCSL has compiled. Sounds like there's a lot of work that's been done in different states around the country, and I imagine they have something. Thank you so much.
Other questions, other thoughts? Anybody ready to vote on this yet? Okay, that's good, because I still think there's some pieces I'd like to have before I made the decision, and so we can defer to another work session down the road. Actually, I think there's one already on the calendar, right, Anna?
There is, Senator, on the 3rd.
Yeah. Okay.
It's not been advertised, but it's
Right.
been scheduled. Yes.
Yeah. Okay.
I don't know if you still need to table it though.
I was going to say, ask, do we need?
We'll do it. We'll do it officially, but I just wanted to get a sense of the committee before I went too much further. I want to make sure everybody's had a chance to ask any questions they have about this complicated and big decision. So I'm not seeing any hands up. So this is not a shy group. I will trust that there aren't any other questions to go. And to that end, I would entertain a motion to end this work session.
So moved. Second.
I think we can do this with a show of hands. So that's the end of the work session on 1701. Anything else we need to do before we finish for the day, Anna?
No. So I'm sorry, I'm not the person that knows the procedures. You don't have to table it. You just end the work session. Is that right? I have no idea.
Well, we'll do both.
Okay.
I'll make a motion that we table 1701 until a later work session.
Second.
Okay, we'll vote on that too. So it's been tabled and closed and tabled. There we go. So I think we covered the waterfront on that. Any other possibilities? So that being the case, I'll entertain a motion to adjourn for the day. Thank everybody for being here.
Motion to adjourn.
All right, all those in favor. Thanks for stopping by. Take care. See you tomorrow.